Today's topic will focus on critical care ultrasound beyond our familiarity with this modality in terms of procedural guidance. Bedside ultrasound is not intended to replace formal echocardiography or formal radiological studies. It has its own purpose separate from those two entities, and we will discuss that specific role during the talk today. The FATE protocol is a term that was derived to describe what we do at the bedside with our focused transthoracic evaluation. The key word in this protocol is focused. Focused assessed transthoracic echo. It's critical that we have a question in mind when we're scanning a patient at the bedside. What we want to do initially is exclude obvious pathology, assess wall thickness and chamber dimensions and static measures, and assess contractility, which are more dynamic, as well as imaging the pleura bilaterally, because anything that happens in the thorax can certainly impact hemodynamics and preload. The most important step, however, is to relate the findings to the clinical context of your patient. Harken back to the question that you have in your mind and see how what you find fits into that question. If you see something that doesn't fit, then try not to force it to fit. For instance, if you have a patient who has good urine output, good mentation, normal blood pressure, if you happen to find an inferior vena cava that looks like it's slightly dry, or a heart that looks a little bit empty, it's not appropriate to hook that patient up to fluids and give them boluses because it doesn't fit with the patient's clinical needs. In more than a third of the cases, bedside echoes revealed new information that was unexpected but did help with the clinical context of the patient understanding. And in about a quarter of the cases, the imaging that was obtained was decisive in allowing a treatment protocol to go forward. More recently, January 2010, from the emergency medicine literature, the RUSH protocol was proposed. RUSH stands for Rapid Ultrasound in Shock. And this is a three-step algorithm to help us organize our approach to the hemodynamically unstable patient. It's very simplified, but it covers all of the bases, and if you can find an algorithm that works for you and you can go through it each time, then you are much more likely to be able to understand the physiology of your patient and make a treatment decision that's appropriate. The three-step algorithm looks at the pump, and in terms of the pump, it is assessing LV contractility, right ventricular function and strain, and pericardial effusions, which may be hemodynamically significant. The tank is then looked at in terms of the IVC to not only see if the tank is full, but to see if the tank is leaking, or if there's any compromise, any external factors that are compressing on the tank in terms of not allowing preload to come back to the heart. The pipes is the last step, and in here we look at the aorta and the major veins in the legs, for instance, deep venous thrombosis in the femoral and popliteal. Another proposed organization of the RUSH protocol is the term HIMAP. It doesn't really matter which one you choose, it just matters that you have an algorithm that you go through so you don't miss anything. HIMAP stands for heart, which is essentially the FATE protocol. The IVC assessment for volume status. Morrison's pouch, which is an indication of leaking of the tank, whether there's intra-abdominal fluid. Aorta and veins, and the pleura. Just as a background reminder, shock, when you approach a patient with shock, there are several categories of shock, and it's important to try and place your patient into one of those categories. It's not always obvious which category the patient falls into. Sometimes it is much more obvious after we evaluate the patient with ultrasound. The first major category of shock, and probably one of the most common, is hypovolemic shock. This can be either absolute hypovolemia, such as in hemorrhage, dehydration, or other fluid losses from the GI or renal tract, or relative hypovolemia, which is a distributive type of hypovolemia where the absolute volume did not decrease, but the distribution of the tank increased significantly, and therefore the effective volume is not adequate. We see this in sepsis, adrenal insufficiency, neurogenic shock, and other vasoplegic states. Secondarily, from hypovolemic shock, either absolute or relative, is cardiogenic shock. Sometimes this is in description of diastolic dysfunction, which we often see in the setting of hypertension or tachycardia. But more often than not, when we're talking about hemodynamically unstable patients, we are describing a systolic dysfunction phenomenon, and this can be either global, such as in cardiomyopathy or Takatsubos, or regional in an ischemic situation, coronary artery distribution, or it can be structural with an acute systolic failure due to acute valve failure. Lastly, and most interesting findings often seen in this category on bedside ultrasound is obstructive shock. And here we're talking about any number of things that can impair outflow of blood from the heart or inflow of blood to the heart. And this can be physiology such as HOCM with SAM, which we'll describe more later in the lecture, massive pleural effusion in ascites, tamponade, tension pneumothorax, and pulmonary embolus. So in keeping with the Rush protocol, we first evaluate the pump. So we're going to talk about cardiogenic shock first and focus on the left ventricle initially. It's also important to evaluate the right ventricle, but we'll take this stepwise. So the qualitative assessment of the left ventricular size and function is what we focus upon. We do not try to put a number on ejection fraction, and there's multiple studies to support that the eyeball method of evaluation of the left ventricle is perfectly adequate and very easy to teach people to use. So here we have three different left ventricular function examples. We have a normal, moderately depressed, and severely depressed. We will discuss what makes each one of these fall into the categories that they do. For normal left ventricular function, we're focusing here on the left ventricle, which is this chamber here. What we're seeing is the left ventricle squeezing the walls, thickening, and the walls coming towards the midline. We see a significant change in the chamber size with each contraction, indicating a relatively decent stroke volume. The right ventricle is adjacent and is usually about 2/3 the size of the left ventricle. We will talk in more detail on that shortly. Another view of the left ventricle from the parasternal long axis view we have here is the left atrium, mitral valve, left ventricle with the septum and the free wall. And this is the aortic valve and the aortic valve outflow tract, and the right ventricular outflow tract. Not the whole right ventricle, but part of the outflow tract. You'll notice there are a few things in this view that we look for in evaluating left ventricular size and function. We are looking at the mitral valve briskly opening and smacking the septum as a marker of a normal left ventricular function. This is just one marker. Taken in isolation, it's not adequate, but when put in the rest of the clinical picture, is something that we look for assessing the left ventricle. In addition, we're going to look back in the chamber, just like we did in the apical 4 chamber view, and we're going to see that the walls thicken and the chamber size decreases significantly with each stroke. This is another marker of normal left ventricular function. Compare this view of normal function to the next view and see the differences. Here we have the mitral valve floating open because flow is so low and cardiac output is so low that it's only causing the mitral valve to float open. We see relatively no change in the chamber size, and the septum and the free wall are not thickening significantly. So this is relatively poor. So here's a severely reduced left ventricular function from the apical 4 chamber view, with the left ventricle here and the right ventricle here, mitral and tricuspid valves. In this picture, we can really appreciate a dyskinetic septum, and dyskinesis means not going in the direction it should. So during diastole, when this mitral valve opens, you would think that the ventricle septum would go towards the right ventricle as the left ventricle fills. And in this case, you can see it's randomly swinging one way and the other, and it doesn't seem to be correlated with the cycle of cardiac function. And this is probably indicative of a septum that is non-functional. Additional findings that you might find in a patient who has poor ventricular function that we will touch on briefly is the inferior vena cava being full, plethoric, without much respiratory variability. And you might also appreciate B-lines, which are these comet tail artifacts that extend all the way to the edge of the picture and indicate pulmonary edema or extravascular lung water. And this is a view of the thorax. Going back and evaluating the right ventricle, we are looking for different things. The right ventricle has a different muscularity, different orientation of the fibers, and a normal right ventricular contraction is somewhat different from a left ventricular contraction. In this case, we see an example of normal, and the right ventricle again is 2/3 the size of the left ventricle. We also see that the tricuspid annulus is squeezing towards the apex with each beat. It should be briskly moving and being pulled up towards the apex. In the second view, we have right ventricular failure, isolated. What you see here is the right ventricle is enlarged. It is more than 2/3 the size of the left ventricle. Anytime the right ventricle is the same size as the left ventricle, then that is moderately enlarged right ventricle. If the right ventricle is ever larger than the left ventricle, then that is severely enlarged right ventricle. In this view, we see the right ventricle as large or slightly larger than the left ventricle. The left ventricle seems to be looking good, and the right ventricle is large, and the wall appears to be stented open. This is an example of biventricular failure, where not only the left ventricle looks poor, but the right ventricle is enlarged, and you don't see this tricuspid annulus moving towards the apex as we would like to. So this is an example of biventricular failure, as you might see in cardiomyopathy. Closer look at the right ventricular failure. You'll see the enlarged right ventricle, the tricuspid annulus not moving nicely towards the apex, and the left ventricle looks good, squeezing, coming in towards the midline. Closer look at the biventricular failure, and you will see the same findings. But in this picture, the left ventricle also looks like it's affected. After looking at the left ventricle and the right ventricle from the long axis views of the apical four-chamber and the parasternal views, we can turn the probe 90 degrees and get a short axis view of the heart. In this view, what we're seeing is the left ventricle in circular pattern here, and the right ventricle sitting atop. In this case, you can see the right ventricular is significantly enlarged. Normally the right ventricle looks like a small beret sitting on top of the circular left ventricle. In this case, the left ventricle is neither circular nor is the right ventricle small. We also see that when the mitral valve, which is this structure here that looks like a fish mouth, opens in diastole, that the septum is moving in the direction opposite to what you would expect. Normally the septum should move into the right ventricle during diastole. In this case, because the pressure and volume in the right ventricle is overloaded, we end up with a flattened septum, something we call a D-shaped ventricle or a D-shaped septum. And this is somewhat classic for acute right ventricular pressure volume overload or hypertension. You might see this in pulmonary embolus. So we've talked about the pump in terms of left ventricle and right ventricle, size and function. And now we're going to talk about the tank and pipes. This is probably the number one question that comes up. People wanting to know, is this patient who is hemodynamically unstable going to be fluid responsive? And what we really are asking there to translate is, what is this person on the steep portion of the Frank-Starling curve? The steep portion of the Frank-Starling curve, as a reminder, tells you that if you increase the preload, then you will also increase the stroke volume. If you're too far out and your tank is too full, increasing preload does not increase stroke volume, and those are the patients that are not volume responsive. So we want to identify the patients on the steep part of the Starling curve so that we know that our therapy of fluid boluses will be effective without causing harm. There are static parameters that we look at traditionally, such as probably the most common one is CVP, and IVC diameter, just a number, static. Our recommendation is to not consider these static parameters. A single number does not give you an idea of where the patient is on the Frank-Starling curve. There are so many things that can affect CVP, for example, such as intra-abdominal pressure, PEEP, tricuspid regurgitation, that relying exclusively on a CVP to tell us where the patient's volume status is erroneous and will lead to improper decisions. Instead, we recommend looking at dynamic parameters. And here we have to remember the respiratory cycle. The important thing to remember is when the thorax is at relatively negative pressure, such as in this picture here, that is when venous return is improved to the right ventricle. Several beats later, this venous return gets to the left side of the heart, and we should then see an increase in stroke volume if the patient is on the steep part of the Starling curve. If we don't see that, then we would suspect that the patient may be on the flat part of the Starling curve. In the opposite situation, when you have increased intrathoracic pressure, such as a patient who is on a ventilator during inhalation, or a patient who's spontaneously breathing while they exhale, if the relative pressure in the thorax is elevated, then venous return is impaired. And that would likewise decrease cardiac output if that patient is on the steep part of the Starling curve. The things that we can look at to evaluate volume are IVC distensibility index, delta VTI, delta Vmax, and these sound more complicated than they are, passive leg raise, which is a modality that we don't use enough, and the hyperdynamic kissing papillary sign, which is a qualitative evaluation of volume status. IVC distensibility index is probably the most used thing that we teach. And what it is looking at the inferior vena cava during the respiratory cycle. This is the inferior vena cava, this is the liver on the other side, and the IVC running through the liver. You can appreciate that it's the IVC because there are hepatic veins draining into it, and it's running through the liver instead of behind the liver. And also it's running into the heart, the right atrium, which you can see a little bit better off the side, the motion off the side of the film. The IVC can also look like this in a patient who's breathing and not have much variability. We can place an M-mode line, which is a motion mode line, through the inferior vena cava, about 2 centimeters distal to where it enters the right atrium and behind the first hepatic vein right here. We can place an M-mode line, press the button twice, and see everything that happens along that line over several seconds, and then freeze the frame and measure with our calipers. And what we see here is if you take the maximum diameter minus the minimum diameter and divide it by the mean, that a 12% or greater finding is someone who is likely to be volume responsive, and this has been studied and duplicated in multiple studies. Likewise, we can place a pulse wave Doppler across the aortic valve outflow tract and evaluate the stroke volume through the aortic valve. This negative deflection envelope represents stroke volume through the aortic valve. And here, even without measuring you can appreciate that with respirations there's quite a difference in stroke volume over time, and that's the qualitative evaluation. But you can also measure the minimum and the maximum and put them into the same formula, max minus min over the mean. And if you again come up with a number greater than 12, then those patients are more likely to be volume responsive. Lastly, we can measure the envelope and the area under the curve of velocity timed integral minimum, maximum, and put this into the formula. Here the cutoff is 20%, but essentially the same concept. Max minus min over the mean greater than 20%, these patients have been shown to be volume responsive. A cheap and easy study that we don't utilize enough is the passive leg raise. And this is a maneuver where you take a patient who's been sitting 45 degrees and put their head down flat, their legs at 45 degrees, passively. It has to be supported without the patient performing a Valsalva maneuver. It's about equivalent to a 1-minute auto bolus of 300 to 500 cc's, which is safe and reversible. This maneuver has been validated in diverse populations, including ventilated, non-ventilated patients, and patients in atrial fibrillation. What they found is that if you find pre-leg raise versus post-leg raise change in Vmax or VTI to be greater than 12%, then those patients will have about a 15% change in their stroke volume with fluid challenge, and therefore a 15% increase in their cardiac output, assuming no change in the heart rate. This is a fairly good test, sensitivity in terms of sensitivity and specificity. Another qualitative evaluation, kissing papillary sign. What we're looking at here is the papillary muscle level, where the mitral valve chordae tendineae attached to the free wall and the septum. And what we're seeing is, in a hypovolemic patient, that the walls essentially kiss during a systolic maneuver. The stroke volume is so high that the ventricle is emptying and the walls are touching. This is a marker of hyperdynamic function, which we often see in hypovolemia and in distributive shock, which is the relative hypovolemic state. You see this, and you have to worry about a patient being hypovolemic. Moving on from if the tank is full to whether the tank is leaking, we can assess using our low-frequency probe, which we use to assess the cardiac, or a C60 probe, which we look at the abdomen with. We can assess for free fluid in the abdomen. This is essentially the FAST examination. FAST stands for Focused Assessed Sonography and Trauma, and it derives out of the surgical world and emergency medicine world. But when a trauma patient comes in, this is one of the first tests that is done to look to see if there's free fluid in the thorax, around the heart, and in the Morrison's pouch, in the splenorenal recess, or retrovesical, retrobladder. And in a trauma patient, if there's free fluid seen in these places, that is blood until proven otherwise. This is a representation of the liver and the right kidney, and the pouch between is called Morrison's pouch. One of the lowest places on the abdomen where free fluid is likely to collect if it's present. This is the diaphragm, the liver, and the lung, with a black stripe of fluid around the lung representative of a pleural effusion. In a non-trauma patient, that's likely just a pleural effusion. In a trauma patient, we worry about hemothorax. In this view, we have the spleen and the left kidney, and the splenorenal recess between, where we would look for fluid. In the bottom view, we have the bladder, and behind the bladder, we would look for free fluid. This is superficial to deep. We're looking behind the bladder to see if there's a stripe of black fluid. Some examples of what a positive FAST scan would look like. Here, we have the liver and the kidney interface with a stripe of black fluid between. That would be abnormal in a patient who was just in an accident. And here we have the bladder with a stripe of black fluid posterior to the bladder wall. It's very clear where the bladder wall is, and that black fluid is also outlining some bowel, and you can see the loops of bowel. So now we've looked at the heart, the pump, and the tank, and we move on to look at the pipes. In this view, what we're seeing is from superficial to deep. This is the spine in cross-section with the spinal canal, inferior vena cava, aorta, and some of the branching vessels. And this is the liver. So as you move from subxiphoid region all the way down to the bifurcation of the aorta, we're looking at the aorta. There's the bifurcation right here. We're looking at the aorta to see if it has its integrity, if it's the normal size, or if it potentially has a dissection or a leak. This example is approximately normal. Each one of these markers over here is a centimeter, and the aorta is essentially around 2 centimeters in most. By contrast, this is a patient who came in with chest pain, back pain, and an evaluation of the aorta revealed something in the aorta, so a longitudinal axis was obtained. And this is obviously the thorax. You can see the heart beating here. Liver, longitudinal aorta, and what we see is this hyperechoic stripe, which represents an aortic dissection. The same patient, from a peristernal long axis view, we get an idea that the aortic root is very enlarged, and that we have an insufficient valve with backflow during diastole through the aortic valve, so aortic valve insufficiency. You can also appreciate very subtly this descending aortic circle here. You can already appreciate the flap, the dissection flap that we saw more distal. Other pipe issues besides dissection, you can also appreciate enlargement. Again, 1 centimeter, with a normal being 2 to 3 centimeters depending on the gender. This is clearly an enlarged aorta, a triple A. You can also appreciate a thrombus in the wall. So a finding of this in a patient who has belly pain and hypotension would be rather significant and immediately inform your decisions. Outside of the arterial world, in terms of looking at aorta, we can look at the venous, major venous portals. And what we're looking at here is the femoral vein and the popliteal vein to evaluate for deep venous thrombosis. Rather often, if we have a hemodynamically unstable patient who we suspect a PE, we can look at the right ventricle and see some signs of strain. And when you look down in the legs with a downward compression on the femoral vein, if the vein does not completely coapt or the front wall touching the back, then we have to be concerned that there's something inside the vessel keeping it from collapsing. Same with the popliteal. This is the right femoral vein with the arteries lateral, vein is medial. And this is the popliteal. You can't tell whether it's right or left, but the popliteal vein is always superficial to the popliteal artery, or what we call pop on top. And in both cases, both of these scans are concerning for deep venous thrombosis because the walls of the veins are not collapsing. Moving on to obstructive shock. These are the processes that physically impair the cardiac output, and it can fall into categories of pump or tank. What we're going to look at are some examples of pneumothorax, pericardial effusion, PE, abdominal ascites that's massive pleural effusions, and a HOCM with SAM. For pericardial tamponade, this is a subcostal view or a subxiphoid view where we look through the liver, through the diaphragm, to the thorax. We run first into the right ventricle and then into the left. But the pericardium that usually lines the heart, the two layers of the pericardium, should be together. In this case, we see a bright white layer of the parietal pericardium and the bright white layer of the visceral pericardium and a black stripe between, and that black represents the anechoic fluid. You also appreciate in diastole that the right ventricle is having some collapse, as if there's someone jumping on the outside of it. And this is an indicator of pericardial tamponade, and recall that tamponade is a clinical diagnosis, so with hypotension, tachycardia, elevated neck veins, muffled heart sounds, EKG, and ultrasound, you can put the picture together that the patient may have this condition and activate and mobilize the cardiology or cardiothoracic help sooner. Pneumothorax. Here we can appreciate the pleural line of the pneumothorax. However, this patient is, as you can see, upright. Patients who are supine, however, the air from the pneumothorax will collect anteriorly, and chest x-ray is much less sensitive for finding those patients. Instead, ultrasound is far superior to chest x-ray for supine patients, and many of our patients are supine or not fully upright. We can find such things as a lung point, which is the point at which the lung falls away from the chest wall and becomes a pneumothorax. On the side that's normal, we see lung sliding at the pleural interface with breathing, and at the side, with the lung falling away here, we lose our sliding. All we see is the parietal pleura. And then we see A-line artifact, which is a marker of air, which you can see either in a normal lung or a pneumothorax. If we drop an M-mode line through the pleural line, then we can see on a pneumothorax side what appears to be a stratosphere sign or the barcode sign with stripes all the way across. On the normal side, we see sky, ocean, beach. What appears to be the sky, waves on the ocean, horizon, and then the grainy beach. The motion of the lung back and forth as it slides creates this grainy artifact. When the lung is not sliding, you do not see this grainy artifact, which is a hint as to a pneumothorax. Chest x-ray is the best study we could find, was 75% sensitive, but most are more in the range of 50% sensitive for pneumothorax in supine patients, but ultrasound has much better test characteristics. Pleural effusions can be hemodynamically significant. In this case, it's hard to orient yourself to this picture because it's so abnormal, but this is the short axis view of the left ventricle. This is the spine. The heart is all the way in the right side of the chest with a massive pleural effusion pushing the lung and the heart over to the right side of the chest. In this case, all the patient needed was a chest tube and their hemodynamics were stabilized. Likewise, intra-abdominal hypertension or abdominal compartment syndrome can occur with massive ascites. What we're looking at here is a very cirrhotic, shriveled up liver. And the diaphragm with a lot of ascites both above and below the liver. In a hypotensive patient, this may represent impaired preload, and a drainage through a paracentesis may significantly improve hemodynamics. Another obstructive shock, and we've seen this picture before in terms of isolated right ventricular failure, we have what PE looks like often. We have the right ventricle that's enlarged, more than 2/3 the size that it should be. And we also see in this view what we call McConnell's sign, which is right ventricular lateral wall akinesis or dyskinesis, hypokinesis I should say, and then apical sparing, where the apex is actually working rather hard, but because of the acute nature of the pulmonary hypertension, the apex is not successful. We also see here the left ventricle is working overtime because it is very empty due to the obstructive nature of the right ventricular outflow. McConnell's sign has been said to be very sensitive and specific for PE. In this patient, if you see this and in the right clinical context, you might think about looking in the leg and performing downward compression on the femoral vein. If you find a non-compressible vein, then that's a DVT. And the clinical picture is significant enough to start therapy. This is especially helpful in our patients who are too unstable to go down to the CT scanner or who have another reason not to have contrast. These findings in the right clinical context can guide your therapy in real time and get the patient the therapy that they need. The last example of obstructive shock is probably one of the most fun to find because it's a physiology that only ultrasound can really help you understand. HOCM with SAM, or hypertrophic obstructive cardiomyopathy physiology, with systolic anterior motion of the mitral valve. What we see here is a very small LV chamber and a very thickened septum, and usually proximally thicker than distally. And what occurs during this scenario is when these patients get hypovolemic, the mitral valve sticks to that proximal hypertrophy septum, and in the beginning of systole, blood is not able to go out the aortic outflow tract. Instead, it goes out the mitral valve and creates an acute mitral regurgitation. So this patient might present with rales, shortness of breath, tachycardia, hypotension. Maybe not the hypotension, sometimes it is hypertension in these patients. In this case, the natural response without the ultrasound is to think patient has rales, we should give Lasix. But that is actually quite the opposite of what the patient needs. The patient under ultrasound would give you this picture of a very hyperdynamic left ventricle that's empty, an IVC that is empty, and rales. And this combination, rales or pulmonary edema, this combination should lead you to think, is this patient hypovolemic? And would a few liters of fluid bring that mitral valve away from the septum and allow blood to go